today, tomorrow, she's gonna be 40 weeks. And, you know, again, the reason I tend to be kind of loosey-goosey is because unless you're an infertility patient or something like that, there's not a huge difference between being 14 weeks and 6 days versus 15 weeks, all right? The other thing, as I mentioned, we tend, you know, OB nurses tend to think from L&P, but when we talk about fetal development, we talk about when fertilization occurred. So when you look at ultrasound reports, sometimes they're off by 2 weeks. A lot of times they will not change the patient's due date if they're not any greater than 2 weeks. So let's say that you came up with a due date of November 7th, but the ultrasound said the due date was November 5th. They'll stick with November 7th because it's really not substantially different. So we mentioned EDD, estimated date of birth, or EDD, estimated date of delivery. We no longer use the term EDC, which is estimated date of confinement. That was an historical perspective when women stayed confined in their homes to have a baby. So trimesters, we have first trimester, second trimester, and third trimester. We will talk a lot about trimesters. Again, the most vulnerable period for pregnancy in terms of fetal development is in the first trimester. And that's, again, unfortunately for a lot of women, they don't even know that they're pregnant. So here's some key points. Again, I think the book uses like 4 pages to talk about this, and I have put it on one slide and the need to know information. So I feel like if you got this slide, you got what you need to know. So at 4 weeks, the baby's heart begins to beat. Why is that important? It's important because right around 6 weeks or so, we can get heart tones. Remember, this is 4 weeks from fertilization. I said 6 weeks, okay? Once you get heart tones by ultrasound, you should always get heart tones by ultrasound. So let's say you have a patient who comes in to your ER, you're the nurse taking care of the patient, and she says, I think I might be pregnant. My last period was about 3 weeks ago, and I had a positive pregnancy test 2 days ago. So as the nurse, you put a Doppler on her abdomen to try and get fetal heart tones, but you don't get them. Is that concerning? No. Because it may be that the baby's not small enough, her dates might be wrong, maybe there's a lot of subacute tissue getting in the way of that. So I think as a nurse, I would want to say things like, I'm going to see if we can get fetal heart tones, but I want to, you to be prepared that we may not get them, and everything may still be perfectly okay. It is very devastating as a woman when you're expecting to hear fetal heart tones and you don't. I mean, the nurse is looking and searching, and it seems to be taking a really long time, and normally they get it right away. So I think you need to kind of preemptively prepare your patient that I'm going to look, but if I don't get them, I'll have the doctor come in and we'll look by ultrasound, because sometimes it's just positional, or maybe the equipment's not working or something like that. At 8 weeks, all the organs are formed, and again, 8 to 12 weeks, fetal heart rate can be heard by Doppler ultrasound. So the same ultrasound that you get for your gallbladder, it's the same thing that we use, it's the same technology. So it's non-invasive, it uses gel, it doesn't hurt mom, it doesn't hurt the baby. A lot of times we'll use just a handheld Doppler, and a lot of them are digital, so it automatically just put it on and it'll automatically tell you the baby's heart rate's 152. You have to remember for early, at the beginning, in the first trimester, we will document heart tones as positive or absent. We're not so concerned about the number. Often it's very high. So you might have fetal heart rate in first trimester of 170. We're not like, oh my gosh, the baby's tachycardic, we need to do some things. Whereas at the end of pregnancy, if the fetal heart rate was 170, we would be very concerned by that, okay? So as the baby neurologically develops, the heart rate will start to come down. Again, lots of people want to know what the baby is. So at 16 weeks, this is the gender of the baby can be seen, not visually, like you can't look at her belly and say, yep, that's a boy, okay? But usually by ultrasound, you have to remember ultrasound, it's really good. We have 3D and 4D ultrasound, which is phenomenal, but it's not 100%, okay? So in terms of 100% actually confirming gender diagnosis, that usually comes through some type of genetic test, okay? But again, it depends on when the genetic test is performed. A lot of people are going for that very early blood test on mom because of the fetal DNA in there. And again, 20 weeks, this is quickening. This is where the baby is starting to move. Again, once mom starts feeling the baby move, mom needs to keep feeling the baby move. So my question was, is the baby moving before she can feel the baby moving? And the answer is yes. Okay. The baby is moving, it's just so small you can't feel the movement. At 24 weeks, fetal respiratory movement begins. So this used to be kind of our criteria for viability, and I think we just keep seeing it go lower and lower. We see people who had their baby at 23 weeks and the baby survived. But we get into a really kind of gray zone. It becomes very difficult to resuscitate babies in that 22, 23, 24 week time frame. Every day, every week we can get is better. But again, usually at 24 weeks, the baby is starting to breathe, cannot sustain its own oxygenation, but will have this kind of fine, downy hair and lots of that cheesy lanugo. 28 weeks, we feel a lot better about 28. If I get to 28 weeks, I'm breath of fresh air. It's like, I made it to 28. But we're not out of the woods at 28. We can get even further. So again, but everything after that. And the key thing about 28 weeks, surfactant, because that's essential for helping the baby's lungs stay open. Now, we really want people to carry past 38 weeks. 38 weeks is the definition of term. And so we're saying, wait till 39. And the reason why is the very last thing you do at the end is you get antibodies for mom, but you also kind of add that addition of kind of that brown fat that helps maintain your temperature so that you can regulate your temperature better as a baby after you're born. Because one of the big issues, if babies get cold, they get hypoxic, and it just starts this vicious cycle for newborns. Okay. So whenever we're working with moms, our goal is to get to 38 weeks. All right, so this is from the CDC. I don't think it's in your book, but it's, again, what would you educate parents, moms, dads, partners, anybody who's looking to have a baby? What can I do to have a healthy baby? First of all, I think is getting a checkup. So seeing your healthcare provider, because we want to know if there's any abnormalities there, structural or otherwise. We want to know if you have any type of infections, whether they're sexually transmitted infections or others. You have to remember that a lot of our patients, they might have chronic health conditions. They can't take certain medications in pregnancy. So for example, if I'm epileptic, I have to get off my meds and switch to something else before, several months before I try and get pregnant. Okay. Multivitamins are huge. What particularly do we need to prevent spinal tube defects? Folic acid. Folic acid is water soluble, which means you have to replenish it. Now in the US, we often get plenty of folic acid because it's fortified in our breads and our cereals and things. But if you had a woman that had a history of a baby with a spinal tube defect, whether that was anencephaly, spina bifida, we were just talking about Zika. We're real concerned about Zika, which is, again, transmitted, that causes spinal tube defects. But for those women that have had a baby with a spinal tube defect, they actually recommend a higher amount of folic acid. So in general, for childbearing women, we recommend 400 micrograms, but that can go up to 1 milligram or 1,000 micrograms. And it's still okay, because again, you'll just excrete the excess. So a lot of prenatal vitamins have 1 milligram of folic acid in them. Can you take prenatal vitamins if you're not pregnant? Sure. The main difference in a prenatal vitamin, can men take prenatal vitamins? Sure. There's no hormones or anything in them. Usually they have extra folic acid, they usually have extra iron and calcium. You want to avoid those naughty things like alcohol, cigarettes, drugs. So I think everybody in OB land is very concerned about what medical marijuana is going to do in terms of childbearing. Out west, a lot of folks find medical marijuana as a good nausea alleviator. And so the argument is, what's worse, medical marijuana or Zofran, right? Because they're both chemicals. So you're telling me to take this chemical that was made in a pharmaceutical company versus something that's plant-based, right? And so I think the jury's still out on that one. But I think you're going to have some patients who are going to have some ethical dilemmas about that. If you've ever taken care of a woman that's had severe nausea and vomiting, she doesn't care. She just wants it to work. I don't like throwing up my tonsils every day and being sick as a dog. infections, so these are really bad ones. Do you know CMV? Cytomegalovirus. For normal healthy folks, I shouldn't say normal healthy folks, people who have an intact immune system, we get exposed to it and we often do not get ill with it whatsoever. But if you have a compromised immune system or you're pregnant, it can cause birth defects. Okay. Syphilis can be treated. Did y'all remember Tuskegee? Talk about that in research at all? You know, people had syphilis, they didn't treat it because they wanted to see how it, and you just treat it with ampicillin or antibiotic. Penicillin's very easily treated. Rubella, so most of us are immune against rubella. We had MMRs, but that's again something that we would want. We don't immunize against rubella in pregnancy, so we want to know that pre-pregnancy because it is a live virus in the vaccine. Choosing a healthy lifestyle, and then talking to your healthcare provider. Okay. Again, most vaccinations, if they have inactive, most vaccinations are fine. So that would include things like DTaP would be fine to have. Flu vaccine would be fine to have. We tend to stay away from rubella and varicella. Those are the ones that come to mind that you would not want to get during pregnancy. So on to the physical and psychological